Hey, welcome to Medical Stuff. My name is Mark Frankham. I bought the last pack of tiles, and this is Chris. I'll buy the next pack of tiles, Fingston.
By the way, we're not tiling a bathroom. He's talking about acoustic tiles.
Right. That are apparently, according to Chris's very irate statement, are not soundproofing tiles.
They're not. They try and advertise them that way. But
Right.
it turns out this won't soundproof your room very well.
Right. So that has absolutely nothing to do with today's podcast.
Well, except for the sound quality.
True, but we're talking about strokes.
That's true.
So, I mean, if you're having problems hearing us, that may be a sign of a stroke. Just going to say, if you can hear out of one ear but not the other ear, seek medical attention. Stop listening to the podcast temporarily and go seek medical attention.
Temporarily. But
Oh,
on
we
your
don't
way,
want to lose a subscriber. So,
we
what
want
is...
to seek medical attention.
Exactly. So, what is a stroke besides an iffy song from the 80s by Billy Squire?
Well, so a stroke is, there's two types of strokes, but a stroke is basically any time you have a lack of perfusion to your noggin, to your brain, specifically.
Whoa. Slow down on the medical talk.
Oh, sorry.
Noggin.
Noggin. Yeah, exactly. That's high-tech jargon.
Right. So, you say there's two. Let's just travel with one right now.
Let's talk about...
Pick one.
Let's talk about occlusive, also known as ischemic.
Is this like an occlusive dressing?
Actually? Not really.
No. So, also called thrombolytic.
Not called thrombolytic. Because thrombolytic is a treatment. Thrombolytic means to get rid of a thrombus.
No,
There's a thrombic and embolic stroke. Those are two types of ischemic or occlusive strokes.
Okay.
So, with the I'm actually probably saying it wrong, but with the thrombic stroke, that is where you have some sort of vasculature in the brain, going to the brain, arteries.
Right.
That over time have narrowed or become stenotic, which means stiff and no longer flex, and a clot will actually form in the brain at those spots. Now that differs from an embolic stroke because that's a clot that has occurred elsewhere that has traveled to the brain.
Okay.
And so the treatment with those is thrombolytics.
We don't need to emphasize like that. I understand I was wrong. Okay, I've accepted my wrongness.
Okay, but we've talked about this before.
Actually, as you talked, I realized I was using the wrong words.
And best part, we've talked about this, is I'm not right often, and so when I am, capitalize on that. So those are kind of the two categories that they fall into. And
so for an embolic stroke, how can they fix that?
So for whenever they have a clot in there's two primary ways they fix that. The first is something called TPA, which is tissue plasminogen activator.
And what was the original one called?
I don't know.
Urokinase.
Me too.
No, urokinase was kind of it was discovered in 1947.
Oh, gotcha.
And was named urokinase because it was a plasma activogen, if I'm saying that correctly.
Plasminogen activator.
There you go. Plasminogen activator that was isolated out of the human urine.
Oh, really?
So urokinase. This is the first gen sort of stuff. It was good, but TPA has become much better.
Yeah, TPA is the gold standard according to the American Stroke Association.
Right.
And so what that does, so a tissue plasminogen activator. Well, a plasminogen is something that creates a enzyme that breaks down clots. Mm-hmm. And so if we activate this plasminogen, it creates plasmin, I believe.
I think so, yeah.
Yeah, that then can go and break down the clot. And that is how you can restore blood flow to the brain. Now, the other way is manually removing it.
Which takes a very large drill and tiny hands.
Exactly. Just get some doctor with these tiny hands to reach in there and pinch it, pluck it out. No, that's just done. They actually use, I think it's a stent retriever. It's the same thing, it literally.
Like a golden retriever? Anyway.
So yeah,
stent retriever. It's similar in function. I believe we're talking about the same thing, which is where they do the real-time MRI on the brain in a surgery center. Mm-hmm. And they actually run a wire
from your groin.
From your groin. Although I know on heart attacks that they can actually go from the wrist. So I'm wondering if they can do that for this. Because it's a smaller artery, it doesn't take as long to heal.
Yeah.
But yes, they actually run a wire all the way up into your brain where it is. Now, the problem with this is they can only do it down to a certain size vessel. It does come a point where it's too small.
Yeah, and remember, your vessels get smaller and smaller the closer to the tissue they get.
Right.
They start out large to carry large volumes of blood, and as they get smaller to the tissue that the blood is supposed to get to, as it gets closer to the tissue that the blood is supposed to get to, it gets smaller and smaller.
Well, just like your capillaries in your fingers, and it's the same thing in the brain.
Absolutely.
So that's one of the problems. One of the things they've also done what they found they can do is, as opposed to originally, especially with urokinase, back in the day, this was basically an IV infusion. Mm-hmm. Right? And TPA, as far as I know, is the same way. Breaks up the clot by thinning out the blood.
Yeah.
Well, there's a downside to this. If you have any sort of pronation to a hemorrhagic stroke, which we'll come across here in a little bit, you have any sort of bleeding problem in your body, if you just give the patient a bunch of blood thinner, essentially, well, you can actually make things go too far the other way, where now you have a bleed in the brain.
Yeah.
So we can fix your stroke and cause a stroke at the same time.
Yeah, so so when they give this medication, TPA, they really make sure that it's the right patient for that medication. And that includes history of previous strokes.
Right.
How long has a stroke been going on to where is TPA going to be beneficial in the first place?
Right.
It's a big pro versus con discussion before they give it.
What also I've been hearing that they'll do is, rather than just flooding the whole body with this, they can actually do a similar procedure where they go in and they retrieve the clot, where they go in and they release a small burst of the TPA right at the site.
Targeted.
So that, yes, targeted. And, I don't know exactly the numbers. I couldn't really find good numbers on how successful that's been.
But that's an interesting thought. It makes sense. But
Right.
I didn't come across that. That's awesome.
Yeah.
So, want to talk about hemorrhagic?
Sure.
We want to talk about what a stroke looks like.
Well, let's do hemorrhagic, and then we can get back into like all what we're looking for and what people should look for in a stroke.
Yeah, so a hemorrhagic stroke is pretty much exactly what it sounds like. It is a stroke where one of the vessels in the brain has broken. You have a broken pipe.
Right.
And what this causes, this causes two problems. One, blood that had an intended destination is no longer getting to that destination.
Right.
So the area that should be receiving blood is not, because we have a broken pipe. Second thing, though, is you also get bleeding into the intracranial space, and you start to get an increased intracranial pressure.
Right.
So this fluid that should be in the vasculature is now between the brain and the meninges, which is a tissue coating that goes around the brain, and this causes a whole host of other problems.
Yeah, so you're basically leaking the blood. You're leaking blood into the tissue of your brain, and it's creating a pressure that's causing other parts of your brain to be compressed.
What that can actually do if that pressure gets great enough is it'll actually start pushing your brain out the nearest hole, which is a hole called the foramen magnum in the base of your skull. That's where your brainstem goes down that direction. Your spinal cord pops out that way. Your brain will actually start migrating towards there.
And that's bad.
That's really bad. And it causes a series of signs that we look for known as Cushing's Triad. And that's an increased blood pressure that goes up.
Right.
A heart rate that goes down, which is really the opposite of what you would expect.
Right.
And then irregular respiratory rate.
Right.
It goes fast and slow. And I cannot think of the specific name for that, but that's what we're looking for. It's a respiratory pattern that speeds up. So you're breathing fast, then you breathe slow.
You mean Kussmauls respirations?
That's the one. That's the one.
I feel better about my thrombolytic statement earlier because I just nailed that.
There you go. Buzzing.
Back on top, baby. Back on top. So, yes, this is all bad. Now, ways to fix this.
This is a harder one to fix. One of the things they can do is they can take the broken pipe, per se, and they can actually go in and place a coil. This coil will go around the broken vessel and help the broken vessel stay together, let it heal, and prevent further bleeding. As far as relieving pressure, if there's enough pressure, they can do what's called a skull flap.
Right.
Where they literally pop another hole in your skull. So instead of going down the foramen magnum, it can actually...
Well, by going down the foramen magnum, you run into a whole host of... Because then it's putting pressure on the brainstem and the spinal cord.
And the brainstem controls functions like your heart rate and blood pressure and your respiratory rate, which is why those start having problems when you wedge it through a small hole.
This is the area of the brain they call the lizard brain. It's the most basal form of the brain from way back when.
Yeah.
All mammals have this part of the brain. They may not have...
You ever see that story of there was a farmer, he went to decapitate one of his chickens, and he had swung this a little bit too high, and the chicken lived. They call it a headless chicken, but what it was is, one, chickens aren't that smart. And so cutting off most of their brain doesn't change a whole lot. But the brainstem had remained. And the chicken lived for years after that. He would feed the chicken by basically putting chicken feed in the hole that is now at the top. That's a true story.
Where did you hear this story?
Facebook. But it's true. It is actually true. I might have to find it and bring it up later.
Okay, if we have any listeners out there that can Google this and confirm this for us, that would be amazing.
But it did happen.
I don't know that you could... I'm skeptical. I will leave that at that. I am skeptical of this story. And you did not help yourself with the Facebook statement. So, and we love Facebook, don't get me wrong, but...
Okay, Wikipedia. Mike the Headless Chicken is the first thing that comes up.
Wikipedia is not a good source, my friend.
Totally reliable, Wikipedia. That's actually how I got my paramedic. BBC. The chicken that lived for 18 months without a head, BBC. More reliable than Wikipedia.
Okay, I'll give you that. I'll need to read that later. So
modernfarmer.com.
But anyway, what we're saying is that there's part of your brain where it is your basal reactions. It does regulate your respiratory rate, so you can breathe. These are the patients that are in a comatose state and have had huge damage done to the brain, but they're still breathing.
Right.
The heart rate, is actually regulated by the heart muscle. It's the only muscle in the body that regulates its own rate and everything like that. But the impulses to increase it and decrease it come from this vagus nerve that is in this area.
Yeah.
So, okay. So what are we looking for?
Well, what we're looking for, and what you can look for at home if you see someone doing this, is we have a set of tests. Right now, where Mark and I work, the two scales that we use, one is actually the Portland stroke scale, which is very similar to the Los Angeles stroke scale, if I'm correct.
Right.
And then after that, we're looking at something called C-STAT.
But better because it's not in California.
Very true. It's Oregon. There's a little pride there.
Actually, Portland, Maine.
Is it?
No, I'm just joking.
Okay. Because I might be like...
I actually just made that up, and I'm going to have to look up now to see if it's true.
Because, I don't know. I just know it says Portland on it now, and I guess I kind of jumped the gun on the pride there. But what we use these for is we use these scales to determine if someone is a candidate for some of the stroke treatments we just talked about, and determine if they're having a stroke in the first place.
It's been interesting because I remember when we first started really tracking these things in EMS. Right now the big push to information push is to get last time they were seen normal. Yes. Which can be a little misleading, I feel, but I understand the purpose behind it. And the reason being is that, they went to bed fine, and they woke up with a problem. Well, we take the went to bed fine time as last time they were seen normal because we don't have any other option. But we don't really know when this stroke started. It could have happened 10 minutes before we got here. So, but I remember early on, anything over 6 hours didn't have a good chance of having a good recovery. And I know that our last protocol, it's within the last 24 hours.
So the first one, I'll start talking about the first one, is the Portland Stroke Scale. The Portland Stroke Scale starts off with 5 questions. Okay, so the first question is the patient over the age of 45? The reason being is, unfortunately, the older you get, the more at risk for having a stroke you are. So no, age does not do you any favors here either. The second thing will be if they have a history of seizures. And the reason why we worry about a history of seizures is because seizures can, at times, mimic some stroke-like symptoms. Let's see, after seizures, the next thing that it's looking for is onset of neurological symptoms less than 24 hours ago. Outside of that 24-hour window, the benefit to receiving a medication, such as the TPA to bust up the clot, is greatly reduced. After that, we want to know if they are ambulatory at baseline. That means, do they normally walk? And then the final question is we check a blood sugar and make sure it's between 60 and 400. And the reason we want to make sure that the blood sugar is between 60 and 400 is that either extreme, whether it's over 400 or under 60, can also cause stroke mimicking symptoms.
Right.
Okay. And after that, we move on. Oh, sorry, Mark.
No, Portland, Providence.
Portland, Providence. Okay, yes. Perfect. There we go. But Portland, Oregon, right?
Right. No,
okay.
Yeah, Portland, Providence here in Oregon. So.
Gotcha. Perfect.
Yeah.
So after that, we go on to more of a physical exam. We do several tests.
Right. So one of the things we're going to do is we're going to do an equal grips test.
Yeah.
Which is we just have the patient squeeze your hands and make sure that they're equal
I almost put my hands forward so you could demonstrate.
Right. Well, yeah, that would be very helpful in an auditory format. So
absolutely.
If you could hear Chris's knuckles creaking as I do this, it would be very helpful. No, so you want to make sure that everything's equal. What we're looking for is we're looking for symmetry of strength.
Yeah.
Now, we can do grip strength. We also will do things with the feet.
Yeah.
Where you have them push down like they're pushing on the gas pedal of a car, and then they pull up. You can do where they raise up one foot and see how long they can hold it up, and then do the other foot. You can also do what's called a pronator drift, where they have to, you stick their hands out in front of them, palms up, and you have them close their eyes, and you see if one arm or the other arm drifts off one way. Usually it goes down, but it can also just go straight out.
Yeah.
You know, recently I had a patient who legitimately, his only complaint was some right-sided weakness, but he just could not control his right arm.
Wow.
You know, and we took him in code 3 as a stroke. He was alert and oriented. He, you know, was able to walk, but he had such a specific stroke.
Right. Because I will say I had a recent patient as well and had symptoms almost identical to what you're describing. So I was just wondering if we had the same patient, but
Right.
I don't think so. 'Cause it sounds like...
Yeah, no, it doesn't sound like it's the same patient. But,
like a different area.
You know, and I was talking to, because I'm a field training officer, so I have a brand new employee with me, and he's a brand new paramedic. Really nice guy, doing well, just new. And we talked about going code 3 at lights and sirens versus not. And I said, yeah, we're going to. Because he was of the age limit, his blood sugar was within the proper range, and it had been within 24 hours of the onset of these symptoms. So I'm like, yes, we're going to treat this like a stroke. We're going to make a stroke alert, which is something we say on the radio to allow the hospital to know unequivocally that we're calling this a stroke patient and they need to prepare for that.
Yeah.
We have a stroke alert. We have a STEMI alert, which is a heart attack. You know, we have trauma alerts. I personally want to do a triage alert for those patients that could probably go to triage.
Right.
We're coming to you, code 1, with a triage alert today for a person who's felt poorly for the last month.
Yeah, and going to triage, that's waiting out in the lobby. That's
Right.
what that is.
You still get seen by a nurse. You still get seen by a doctor, but they're going to prioritize by severity over chronology.
And unfortunately, we have a lot of people these days. And Mark, I know you've had this question. They call 911, we get there, and the first thing they say is, hey, this means they don't have to wait in the lobby, right?
Oh, yeah.
Being in an ambulance has nothing to do with that.
No, they're going to prioritize by severity. But anyway, back to what we're talking about. My partner and I were talking about it after the call, and he was like, well, we didn't really have the facial droop. We didn't have the pronator drift to the extreme stance. I said, but the problem is it could still be a stroke.
Right.
I said, it's just like seizures, where you have a full-body grand mal seizure, or you have focal motor seizures.
Yeah.
They're still having a seizure. It's just one doesn't present the same way.
Absolutely. And different strokes for different folks.
There you go.
Sorry, that was super cheesy, but I had to.
You know, so we have the hand grip, we have the pronator drift, we have the foot movements. One that I've seen done is where you put out, and I've done it actually, where you put your finger out and you have the patient touch your finger and then touch their nose. And then you move your finger across the other side, and they have to go cross court to touch your finger again. You do that with both sides.
Oh, gotcha. I've seen that done.
Yeah. Then you have looking for facial asymmetry, where one side of the face is drooping and the other side is not. Here's where you have the people smile at you.
Yeah.
Or say a sentence of some form. And the sentence is really kind of irrelevant. What they're actually saying is irrelevant, as long as it goes on long enough for you to watch both sides of their mouth and see if they're moving things effectively.
And then the other reason you also have them do a sentence is to make sure they can repeat it back to you. And that's the last thing on the Portland Stroke Scale, is you have them say a sentence. And again, it doesn't matter what it is. You want to see if they can repeat it back to you, because strokes can affect your speech centers. And your ability to speak and your ability to hear are not necessarily tied together. So sometimes you can have patients who will not be able to understand what you're saying, but that will also be presented in the fact that they will have a hard time following your commands from the get-go. Or they will speak back to you in ways that do not make sense. I believe a while ago there was a newscaster that actually had a stroke on air.
Oh, really?
And yes, she had a stroke on air and began to say things that absolutely did not make sense, and they caught it.
Right. Well, because we can have, and that can present in two different ways, a couple of different ways. One is exactly that. They go to a word salad kind of thing.
Yeah.
Where they're making, the answers are not coherent with the questions.
They can literally be something like bicycle, apple basket, walking on the sidewalk.
Right.
And they can say that when you ask them to say, can't teach an old dog new tricks.
Right. So the problem is that their brain is not processing, and it can be frustrating for the patient because it makes sense to them.
Yeah. They think they're nailing it.
Right. Because
What's your problem?
Because they're thinking the words properly. Mm-hmm. They're just not able to say them. So that's one thing that can happen. One of the other things that can happen is while they're talking, you will see that drooping or slurring, or they're just not able to phonate properly because they can't control the muscles. I know, phonate. Yeah, it's a 10-pound word, man.
Yeah.
So, these are just things that we're looking for.
Yeah. So the Portland Stroke Scale focuses primarily, out of those, you get the... we ask you to repeat a sentence, look for word salad, we look at facial droop, grip strength, and then the pronator drift. And then when we get into the hospital, physicians will do many of those things that Mark has mentioned as well.
Right.
The next thing we look at is something called a CSTAT test. And so CSTAT helps us determine the difference between a large vessel occlusion, which is just what it sounds like, a large vessel that feeds the brain, versus a stroke that might be in a smaller vessel. And large vessel occlusions are particularly dangerous.
Right.
So...
Well, you're affecting a large area of the brain.
Absolutely. And so that is measured in points. And the way those points work is certain findings are worth points. So the first finding is deviated gaze. Are they looking towards one side or the other?
Right.
If they, I believe it's technically as preferred gaze is what it's listed as. If their eyes are favoring looking to the left or the right over looking dead center, that is worth 2 points on the scale. The next category after that would be if they cannot hold up their arms or arm, depending on your previous stroke findings, for greater than 10 seconds. That's worth 1 point. And then finally after that, it is if they cannot answer one of two questions to determine if they're alert and oriented, and they cannot follow at least one command that you gave in your previous stroke scale. That's worth another point. If they total 2 or more points, that's what we call CSTAT positive, and we're looking at that large vessel occlusion type stroke. So the deviated gaze by itself, that's 2 points right off the bat.
And what this does is it really helps us determine where we're going to go with the patient.
Yeah.
I feel standard protocol, but our protocol specifically states that if you have a CSTAT positive patient, then you can only go to an interventional or stroke. Oh, what's the term I'm looking for? They're a primary stroke center.
Yes.
So they have interventional capabilities, and this is where they're going in with the stent grabber thingy. Medical terminology, I know.
Stent retriever.
Stent retriever. Well, no, because anyway, but they can go in. They can actually remove that clot or break that clot up at the site. And so this is an expensive procedure. It is an expensive procedure, but it's an expensive piece of equipment to have on staff 24 hours a day, to have the staff in there, have the physician that can do it, have the equipment. So, in previous podcasts, we've talked about like a trauma center. You may only have like 1 or 2 trauma centers for a metropolitan area because it's expensive to support a trauma center. So you may not have every hospital, especially smaller hospitals, will not have these interventional.
And that's just a cost versus benefit analysis.
It is.
If you only have, 10% of your stroke patients are even going to qualify for this intervention.
Right.
The cost, and I know a lot of people are like, well, anything is worth any amount of money to save a life.
But world don't work that way.
Absolutely. It doesn't. It's one of those things where if the hospital goes broke,
right,
trying to support every possible patient, then you have no hospital, period.
Right.
So unfortunately, there's
you have to consolidate that patient base.
It's why there's not helicopters on every street corner.
Right.
Because that would greatly slow our time.
Right.
But,
you just can't support that kind of a system. So now the thing is, it's not that the smaller hospitals or the more outlying hospitals don't have options.
No, absolutely not.
If you can't get to a interventional stroke, you can still go to a local hospital and get TPA. The point is that TPA is going to be good, but the interventional system is going to become the gold standard for this.
Absolutely.
So where did the term CSTAT come from?
I couldn't tell you right off the top of my head.
It was actually originated in Cincinnati. That's what the C stands for.
Oh, Cincinnati. Ever since everyone stopped doing the Cincinnati stroke scale, they had to get in there somehow.
Right, exactly.
For the longest time, we did the Cincinnati stroke scale. That was kind of the gold standard. Then it went to the LA stroke scale, and now, at least in our area, we're doing the Portland stroke scale.
Well, but, there may be a home team.
I think, that's kind of what I was thinking.
We got to support the locals. It's kind of like champagne only being produced in France, you know.
So, those are also things that, by the way, you can look for at home. If you have a loved one that you see that suddenly is not making sense when they speak, suddenly one side of their body goes limp or becomes really weak, same with their face, they're not able to smile, those are all good times that you need to call 911. And it may seem obvious, but Mark and I run a number of calls where, he was having some trouble moving his left arm last night and he wasn't speaking quite right, but he's had an infection and so he went to bed and woke up and it was still there, so I'd call you. It's very good to educate yourself about the signs of a stroke.
Just recently I had a stroke that started at 11 o'clock last night.
You look great for having a stroke that started at 11 o'clock last night, though. You're
doing
really well.
Feeling good, looking good. No, it was 13 hours from the onset of the symptoms before they called 911. And part of that is, he wasn't looking that bad. Part of it is the person doesn't tell their loved one that something's going on because unfortunately, they don't want to create a kerfuffle. They don't want to
past generation.
Right.
I don't want to bother anybody.
Right. Yes, we're taking you to the hospital for heart attack. Is there anybody we need to call? Well, no. Well, my daughter, but I don't want to bother her. Okay. I told my mom she went to the hospital for hypertension.
Yeah.
I found out about it 2 days later. And she was like, well, no, it's okay. I said, okay, so if I go to the next time I go to the emergency room, I'll call you a couple days later and let you know about it. Well, no. What is the difference here? But no, they don't want to create a problem. They don't want to bother anybody. It'll pass.
Yeah.
This will be fine. And then it's not.
Speaking of passing, why don't we talk about stroke symptoms that do pass?
No.
Okay.
No, so there is a very simple, I just want to go over one more thing real quick.
Oh, no problem.
I want to go over the very simple, out-of-hospital, non-trained way of telling if you've got, or somebody has got a stroke. What's this called, Chris?
I don't know.
The FAST scale.
Oh, yeah, I do.
And so, I knew you knew. I know you know. You know I know. We all know each other knows, okay? And that's where the podcast spiraled out of control. So
no, it's not. It went way out of control.
It's been gone for a while. We barely maintain here. So, FAST. The first one of those is, Chris?
Facial droop.
Facial droop. So it's something we look for in our stroke scales. Absolutely. If you look at somebody and their face does not look normal.
I don't mean they're ugly. Yeah. I mean they're ugly. Like Mark would be having a stroke right now.
Exactly. Chris, we're going on Chris again. So no, you're looking for facial droop, and this is basically one side of the face is actually just hanging slack. Now, this can also be a number of other things, one of them being Bell's palsy, but Bell's palsy is fairly rare, much more rare than a stroke. So if you see this going on, just go ahead and assume it's a stroke. So the other thing you're looking for in the FAST, and this is an acronym, is going to be their arms. Does the patient raise both arms? Does one arm drift downward? We talked about this, pronator drift. These are, in fact, initially, the CSTAT in Cincinnati was used with the FAST method, and still is, I believe. The next step is speech, or ask the person to repeat a simple phrase, things we've talked about. And then, if you observe any of these signs, call 911, because the T in FAST stands for the time. Yeah, that's what I'm looking at, too. Time is very important in this, because the longer you have an occlusion, the longer that part of the brain is being deprived of oxygen and nutrients. And eventually it's going to come to the point where that part of the brain is just dead and will never recover. And then you're going to have symptoms for the rest of your life because of that.
Absolutely.
So now we talk about time. A stroke is considered a stroke once the symptoms last how long? 24 hours. Because otherwise it's a
transient ischemic attack, or TIA.
Right.
Sometimes I've also heard these referred to as mini strokes.
Right.
And what a transient ischemic attack is you do have the ischemia, which ischemia means lack of blood flow to an area of the brain.
Right.
But it's transient, meaning not permanent. So whatever caused it, for whatever reason, it is now gone, and the symptoms have relieved, typically without intervention from the hospital. And we actually see these TIAs quite a bit. Now, the scary part about TIAs, though, is if you've had a TIA, you are now at much higher risk for a full-blown stroke. One of the common things that will cause a TIA, as we talked earlier, we talked about the different types of occlusive strokes. Well, if you have an area in the vasculature that feeds your brain that is prone to clot forming, those are patients that are way more likely to have these TIAs because they can have clots that form and then dissipate naturally. Because your body does have mechanisms to get rid of clots.
Absolutely.
And so those people are going to be more prone to TIAs and more prone to stroke. Mark, do a stroke scale on me.
Stick your hands out, Chris. Come on. So the problem is that with these TIAs, I don't know how many times I've gone on patients who have strokes, and I've been told, this has happened a number of times, but it always resolved. Mm-hmm. Yeah, that's a TIA. That's a precursor to having a stroke. You should have been actually taking this very, very seriously.
Because one of these times, it won't resolve.
Right.
So let's treat every single one like this is that time.
Exactly. So, yeah, if you see any of these signs and symptoms, we went over the FAST, the facial asymmetry, the arm drift, the speech problems. And again, it could be slurring the words like they're drunk. Yeah. It could be just inability to move the mouth in a way that forms sounds that sound like words. Or it's forming words that just are nonsensical. Then call us immediately. Because even if it self-resolves, and I've had patients who I leave the scene with them, and they've resolved by the time you get to the hospital.
Fixed them.
Yeah, and you tell the hospital staff, and they're like, they look fine. It's like, yeah, but they weren't fine, so.
Oh, I just say, who needs a stroke center? I got this.
Right, exactly.
Clearly, this was my intervention.
But, it doesn't have to be all of those. Any one of those should be enough to be concerning.
Absolutely.
I've had patients who had a stroke, and all it was their legs felt a little weak. Yeah. I had a lady just the other day. Couldn't speak. She was trying very, very hard, Now, we pick these patients up. What can we do for them pre-hospital? Not a whole lot, basically, is what's come down to. We're going to get you to the hospital as fast as we can. Because one of the things that's going to be going on when we get there is, more than likely, they're going to go immediately into a CAT scan or a CT scan. And
that's what Mark was talking about earlier. That's why we pre-alert the hospital with that stroke pre-alert, so they can get that ready. Oftentimes, we don't even put them in an ER bed. We go straight to that scanner.
Yeah. So I had a new person, very enthusiastic.
Oh, I love that. It's so cute.
Yes, it is. And I like that. I do like that. I mean, we joke about it, but I would much rather have a very green, enthusiastic person than, Chris. So, some old medic that's just burned out. So, we have a stroke patient, and this was literally, I feel a little bit dizzy, lay her down on the floor. We get there 5 minutes later, code 3. We're like, yeah, that's a stroke.
Right.
She has all these signs and symptoms. So, very quick turnaround on scene. We did most of our interventions on the way to the hospital. We get there, we walk up to the room, there's a group of people out in front of the room, and one of the people in this group goes, okay, we're going to stop right here. My very enthusiastic partner goes, no, we're trying to get in this room. And I go, yeah, but he's the doctor, so we're going to let him call this one. But yeah, they stop, they do their own quick assessment, and yeah, we turned around while the patient was still on our gurney and rolled him straight back to the CT scan. And they went straight into the CT scan. Now, when they came out of the CT scanner, they went onto a hospital bed and back to the room.
Absolutely.
But now, by the time they get back to the room, a neurologist or an ER physician has seen that CT, and they can start getting an idea of what's going on.
Right. So a CT scanner is going to show, there's two primary things that I can think of. One is going to be, three. One will be bleeding.
Right.
It'll show blood in the brain. Another thing that doctors will also look at is to look at the midline of the brain that divides the two hemispheres and see if it's shifted to either side. If you have one of those hemorrhagic strokes, you're going to have pressure on one side of the brain that's going to shift that midline. Also, they can add contrast to the CT scanner, and it'll actually show them where blood's not going as well.
Right.
As well as where blood is going.
Because it will light up the areas that are filled with blood.
Right.
And so if they have a dark area during a contrast CT, then that shows that part is the part with the ischemia.
Right. What about some risk factors for strokes?
Obesity.
Right. And then, obviously, previous strokes.
Smoking. Increases your chance. Basically, anything that's going to be procoagulative and cause clotting.
And also things like hypertension, high blood pressure.
Right.
We talked about hemorrhagic strokes, pipes bursting. Well, they burst a lot easier under pressure.
Right. Some people will call it, as opposed to a hemorrhagic stroke, I meant to mention this earlier, it would be an aneurysm.
Yeah, absolutely.
You know.
Also, diseases that aren't necessarily related to your vasculature, but that can cause clot forming, such as atrial fibrillation.
Right.
That's an irregular heart rhythm, and one of the things that can happen is blood can become stagnant in the heart, and it forms clots. And those are people that are often put on blood thinners like warfarin to prevent these clots from forming. Fractures of long bones.
Right.
They'll have clots form there. So, well, like you said, anything that's procoagulative that's going to be forming clots.
People who have had surgery and are bed confined for a long period of time.
Absolutely.
You know, because you're just not getting the proper blood flow through certain parts of your body. And so you're going to have clots form. We said obesity. Also, patients who are on birth control.
Oh, yeah.
You know, that's usually a young person's game, so there's always that possibility.
And there have been 911 calls, even in our area, but the nation over, where you've had younger females have stroke-like symptoms, and it's been missed by field personnel in the past, because sometimes people look and say, hey, like I told you earlier, one of our screening questions is, well, are they over 45?
Right.
But when you have other risk factors, that's where the paramedic that thinks outside the book is gonna succeed.
Exactly.
So, luckily, the only call I know that happened locally, paramedic nailed it. Walked in, was just like, 20-year-old female is having stroke-like symptoms. You on birth control? Yes. Calling this a stroke.
Right.
Dead right too.
Yeah.
Not dead right.
Right. No, right. But no, called it correctly and was able to get the patient the care they needed.
Yeah.
So
hometown nailing it.
Yeah. Was it you?
It was not me.
Okay. I figured that was going to be the next part of the statement. Paramedic nailed it. I was the paramedic. So, okay. Anything else?
No, I don't even have any stroke jokes.
Really? The only one I had was my Billy Squire joke at the very beginning, which you probably don't remember Billy Squire, but never mind. You're young.
Yeah, well, and then I also threw it. Well, it's not that I'm young, Mark.
You're younger than I am. You're young enough that you don't remember Billy Squire. How about that?
I think the more accurate way to put this is that you're old.
No.
No, I had different strokes for different folks.
Yeah, I think so. Anyway, thank you all for listening. Please follow us on social media. We're at Medside Stuff on Twitter, and our email account is medsidestuff@yahoo.com. Please send us emails with any sort of questions, compliments. We always take compliments.
Oh, yeah, we like those.
If you like the show, please give us a 5-star review on iTunes. And also any sort of ideas for future shows.
Yeah, absolutely.
So, anyway, have a wonderful evening. Toast.
Toast.